Good afternoon, everyone. Very happy to be here, and thank you, Jen, for kind introduction. Really, there's not a lot more I have to tell. I just like to present myself as I'm a clinician. I'm an internist by training. I treat adult hemophilia patients, so patients with bleeding disorders. They have joint disease, and pain is a daily component of their life experience. So that's my clinical connection with pain. But it's not really with that art that I'm here today. It's more my main job here at McMaster is to explore new ways of bringing research result to the public, specialist, non-specialist, health professional, and lay public. And in that perspective, we have developed PAIN Plus, and PAIN Plus is a product of the SPORE Chronic Pain Network, and was developed as the KT platform of these CIHR funded study. So I want to acknowledge funding from CIHR. We co-funded the project as McMaster, but we are really thankful for this opportunity of networking with these large Canadian network. The objective for my talk today are essentially to communicate to you what the premium literature surveillance service here at McMaster is, how that integrates with the PAIN Plus chronic pain network, what the scope is for that initiative, and what is an evidence summary. I will try to communicate how it's possible to help us selecting evidence summaries, verifying them, and if any one of you see value in what we are doing, there will be indication about how to become a member of our jury and help us in our work. Now, this is the PAIN Plus CPN landing page, and there's space for professionals. We'll see a little bit toward the end. So healthcare professional can register here for free and sign up for receiving alerts or browsing our content. But where I want to start is from the evidence summaries. So if you click up there without any need for registration, you see a list of patient summaries. And these are usually titled with a question. And the question is one of those that you would imagine a patient could ask his doctor. Doctor, I have plantar heel pain. Is it better for me to consider orthosis or steroid injection? Or I have chronic pain with anxiety and depression. Will it help me to try transdiagnostic emotion focus treatment, and so on? So is essentially bringing research result, single pieces of research in a lay format. If we choose one of these, let's take this one on chronic joint pain, not a rare condition for sure. Will therapeutic ultrasound help me manage my pain? If you click on that one, you'll see a bottom line. It's usually one sentence, sometimes two. I'll just read it through. For chronic knee or shoulder pain, therapeutic ultrasound may have some benefit for some people for managing pain, but others may receive no benefit. Other treatments may be more effective for managing knee or shoulder pain. There is not any evidence about whether therapeutic ultrasound is helpful for chronic hip pain. Is sort of distilling down the content in a format that hopefully is understandable to the lay public, but it's not all here, of course. You can scroll down, and if you find anything that is interesting for you in the first summary statement, then the result of the research are reported still in lay format, but with some more detail. So for example, focusing only on this piece, it says this review did not find any articles on therapeutic ultrasound for chronic hip pain. So the statement that we don't know if it works in chronic hip pain is because there is no research to support any conclusion there. And the other is about safety. There were no adverse effect or safety concern in using this way of alleviate pain. So, you know, the main statement was it may work in some patient, it may not in other. And one might say, well, okay, what do I lose in trying? Worst case, you lose time, you may lose money, but there are no side effects. So it's a sort of progressive disclosure. And if you say, well, okay, some of these results are actually interesting, but which kind of study is this one? How strong this research is? Then you can scroll down again on the page, and there are more details about the methodology of the study, who took part in the study, and so on. The way we doctors or we scientists write paper is exactly the opposite. We tell the entire story. We want to show where we started with our idea, which method did we use, what we did, and finally we draw the conclusion. And that's okay. That's the way scientific papers are written. But when you think of someone who has a question, they want an answer. So we are reverting completely the process. And so, for example, you want to know, you are curious to know how many studies, how many patients were observed to come to this conclusion. And is this little blurb, I'll make it bigger for you to be able to read it. So this was a review. So was someone who went on search for all the studies about ultrasound in chronic pain, and they found 15 studies. And these 15 studies were classified. 8 of them, for about 600 patients, were dealing with knee pain. 7, for about 350 patients, were dealing with shoulder pain. And there were no studies about chronic hip pain. How long were these studies? For how long these people had pain? Well, for at least 3 months. So again, is all there, is in simple language. You read it, you continue reading if you find information that is useful for you. Otherwise, you have gotten already the bulk of the message in the first sentence. You know, just to give you a flavor, I picked another. Chronic pain and cannabis. Can that help? Again, one line, bottom line of this research. Cannabis may help to treat chronic pain. It may work better for neuropathic pain than for other kinds of chronic pain. Now, you may say, well, neuropathic may be too complex. Why you have not used the term that is simpler for patient to understand? And I would take that criticism, and this is actually not one of the last we did. And very often someone send us a note saying, you know, that word is not really lay, is not really something everyone would understand. Why don't you change it with? And we have a pool of patients with pain that receive our draft and make comment on those. So again, I'm not shy showing that even if we do our best in making them simple, there might still be something that is jargon. Again, if you scroll, you would see which kind of study that is, was another review. We tend to summarize review whenever they are useful for their content because they are more robust. You know, in this case, the judgment on can cannabis be of use is made out of 43 studies, and all those studies are randomized trials. I will show you in a minute a solution we are experimenting for solving, again, this leftover jargon. What is a randomized trial? Well, is an experiment where patients are assigned by chance to receive treatment or something else. And you see here on the left side, so this patient received cannabis, but also received a comparator. So cannabis was compared for its efficacy in these 43 studies with placebo, so a sugar pill, a active pill or with weak opioids or anti-inflammatories, naproxen in this case. And these 43 studies enrolled more than 2,000 patients with any kind of chronic pain, both cancer and non-cancer. Again, chronic pain defined as lasting for over 3 months. If you were to go directly to the original review to find the information that is on this slide and to translate it, still there is some jargon, but to translate it from the scientific language to something understandable would take you likely a few hours. That's what we try to do with the evidence summary. We try to take a patient or lay citizen standpoint and distill down in a standardized way the content of scientific papers. I hope that the two examples were enough to give you a flavor of what a evidence summary is. Here are some other titles. I've been taking opioids for my chronic pain condition. I want to reduce my dose. Will my pain get worse if I reduce my dose? Again, taper. Taper is technical. The new version of this one has reduce. Taper, means reducing gradually, but reduce would have the same effect and maybe easier to understand. Doctor, I'm taking opioids for my chronic pain condition, but I want to reduce my dose. You see the evolution? This is more recent. Will electroacupuncture help me reduce my opioid dose? So this is a slightly different question. Can I get help through this approach while reducing my dose? I have persistent arm pain after my breast cancer treatment. Will myofascial techniques help me treat pain? This is the kind of question we try to answer by broadcasting research result. Now, why is this important? Because if you think, for example, of COVID, yes, COVID is something that was unheard of. There were no other diseases in the last 50, maybe 100 years affecting so broadly the population with such a high impact. But the impact that COVID is having on medical literature is as severe as. It doesn't kill anyone, of course, but the forecast is there will be 50 million publications by the end of the year if we were to continue publishing so fast. And this happens in all fields. I've looked at pain, and if you search for pain in one of the most commonly used database used by doctors, between 2000 and 2020, 600,000 papers were published on some aspect of pain, of which about 1 in 3 is available free, which means you can get as many as you want of those, but do you really need to read all the 600,000? And they are not being flat, actually. This is how many published per day, and I've highlighted here 2000 to 2020, and you see how steep is the rise of what gets published. And looking only at 2019, last year, 50,000 paper on pain, 21,000 free, almost half of them free. And 5,000 of them, 1 in 10, is a review, is a paper saying, okay, I have this question, cannabis efficacy. Let's see how many papers have been reporting research on cannabis that I can draw useful conclusion from. So is a humongous number of publication out there. Now, as often in life, we don't need everything. So if you think of the evidence, the research evidence that end in being useful and applied, is shaped as a pyramid. So at the bottom, you have all research results. Every kind of study that is done, including in vitro study, in tubes, or animal studies, or very preliminary exploratory experiments. All these research results lives in clinical trials or in laboratories. Not all of them will be communicated. Is research that is needed, needs to happen, informs other research, but there's a good chunk of these that remains in the unpublished space, just because there are no relevant results or they are preliminary to other subsequent experiments. Then we have what we call peer-reviewed research. Peer-reviewed research is the way that the scientific community in healthcare has decided that they communicate sound result of research. If you move to another field, say physics, they don't have peer review. They just put their research result on a website, and people read them and criticize them. And if they like them, they use the result. If not, they are left there unattended. In the healthcare and in sciences, we tend to send results to a journal. The journal send it out to 2, 3, 4 experts in the field, ask for their opinion. If they think it's good, it's published. If they think it requires some modification, it's sent back to the authors, and in the end, is published. This is a sort of a way of warranting that only good results get to be disseminated through journals. So this kind of research you find in medical journals. Not all of that is ready for clinical use. Only a proportion of that research is really relevant for patients. There are still animal studies published there, or there are very initial pieces of evidence. And not everything is patient important. They may explore aspects that don't really need to be known for making a proper use of intervention, diagnostic measures, and so on at the clinical level. So where do you find ready for use patient important pieces of evidence? And of course, these are a subgroup. So we are getting toward the apex of the pyramid. For example, in OClock Class, I will tell you in a second what OClock Class does, but is another level of selection where, starting from the research that was judged sound by peers and was published in medical journals, is selected for being ready for use and patient important. Not everything that is in OClock, I should have said PAIN Plus. This is wrong. So this is PAIN Plus. Apologies for the mistake. But not everything that is in PAIN Plus is worth ending into an evidence summary. Evidence summary are meant to be directed to patient. PAIN Plus is collecting what doctors treating pain, nurses treating pain, physiotherapists treating pain would need to know because it's relevant for patient and ready for use. But the piece that is important that patient directly know about is a smaller subset. And where you find what is directly relevant to patient, ideally, this is what we summarize in the evidence summaries. Maybe not all of them, but we try at least to summarize only what is directly relevant to patients. So how do we get to PAIN Plus? How do we select what is ready for use and patient important? It's quite of a multi-step process that we are undertaking here at McMaster. We are undertaking this for many disciplines, and that's why I got confused and I put on OClock Plus instead of PAIN Plus. I will show you later on an example from OClock Plus that is relevant. But what we do, we have a team of people here, expert in literature appraisal, in assessment of literature. And what we do, we keep under surveillance a set of journals, about 150 journals, including 15, 17 right now, journals publishing selectively literature on pain. And we read through everything that's published there. And we also try to read through very quickly. As soon as the articles are published, we wait maximum 2 weeks. We read through and we select anything that is with a scope. And for scope, we mean is for treatment, is for diagnosis, is for assessing the course of the disease, the economical component. But it has to be original result in one of these fields. The other assessment we do is that for each of these fields, for treatment, for diagnosis, we have a set of rules. A set of rules that have been built, they are the milestone of EBM. A good treatment study has to be randomized, has to be a given size, it has to be reported, not disclosing result in all patients, and so on. If the study fails any of the criteria we have, and we have criteria, 3, 4, 5 criteria for each different scope, as soon as the article fails one of the criteria, we ditch it. We only keep those not failing any criteria. And we don't stop there. This means the article is good. Now we attach a label. Can be on pain, can be on clots, can be on diabetes, can be on, you know, pediatric emergency medicine. All what is on pain, then we send out to a crowd of practitioners, health professionals, doctors, physios, nurses, and we ask them to answer 2 questions. Is this new? Is this relevant? We don't presume to have the expertise to judge what is new, what is relevant to patient. I'm not a pain expert. We are expert in literature appraisal. We know how to distinguish a good study from a bad study, but that's it. For the judgment on relevance and newsworthiness, we need help. And we have about 8,000 people helping us out there. We send this article as soon as they pass the criteria for quality out to raters, and you would be amazed by see how fast we get their judgment. Usually is 1-2 days maximum. And they tell us on a scale 1 to 7, if that is not really relevant, only a few patients would benefit, that's a 1 to a 7. Most of the patients with this specific disease, with this specific kind of pain, would benefit from this piece of evidence, and that's a 7. And in terms of newsworthiness, this is really new. No one would know if not reading this article, that's a 7, or it's a good study, is an important concept, but everyone knows already. That's a 1. We retain only the 4 and 4. And what we do after we get this back, to give you a dimension, we read about 70,000 articles per year. We retain in the end about 3,500. So we cut down by 10, and then again enough. This is key for ensuring that those doctors, nurses, physios treating pain can receive what they need to know. They will never read 60,000 articles. Let's say in pain is not 60,000, is a fragment, about 10%, so 600 articles, still too many to read in 1 year. And before those get into a textbook or get presented in a meeting or get presented in a webinar like this, it may take months, sometimes years. So our goal through the PAIN Plus process is to make sure that relevant pieces of information get to doctors and healthcare professionals more in general in weeks from publication, and they only get what is relevant for them. How they get them? Well, I showed you before, there is this register here if you are a practitioner. What you do, you register, and you can select to receive an email. You can decide how often you want the email, and you may also select some topics. If your specialty or your interest is knee pain or back pain or post-surgical pain, you may select give me only alerts on this specific area. You see here in this example, there are 11 articles alerted to this user, and 1 is still unread. 17, those are generic, those specific on the topic they selected, 17 on those topics, 7 still unread. Now, one can go here and click, see the list and read them, but one can just wait for an email from PAIN Plus to get in your mailbox saying, colleagues in your clinical discipline have identified the following articles as being of interest. And then you have the article in object. If you click on the article in the email you have received, what will happen is that you'll go directly to the piece, and you can read it directly. You don't need to, someone tells you, there is on PAIN, they published this article about the mindfulness stress reduction approach to reduce migraine. It's very good, go and read it. Well, you have to find a library, find a journal, search it, and then you may get this one, get another. You get an email saying this should be good for you. If you have 5 minutes to have a look at it, click here and go there. You also see the rating. This is the average rating of the 5 people, or maybe more, who assess this article. And it's a 5 in 7. So, it's not 7 in 7, but is of some interest, of some newsworthiness. We also treasure on the comments and the ratings that we receive. And so if you click there, you will not only see the abstract, and you will not only have a link to a full text. You will also have, for example, the rating by discipline. So for example, this was rated by psychologists, and psychologists felt this was very important, was a 7 in 7, and was quite new. So the overall rating, pain doctors in general, was 5, but the rating of psychologists was very high. There are links to associated area. So this is about migraine. If you want to read more about migraine, if there is anything else we have selected on migraine, you click there and you see the list. And the comments are here. So those who gave the rating, the numerical rating, have a chance of leaving also comments. And those comments, maybe, like this one, they just say, this is a wonderfully elegant and informative piece of work. It's fine, it tells me, but this other one leaves a longer piece of comment and explain why I think is important, what the alternatives are, and so on. And very often, this piece is like discussing the article with a colleague. You get for free to even before you read, to know what other in your discipline think about the article, and you can add your comment if you like. Now, this is PAIN plus, the usual mistake. So this is what we have selected as useful for pain healthcare professional. How we move to the evidence summaries. Not every single article that get in PAIN plus is used for writing a summary. We need another level of peer review. If you think of it, we are just following the same approach that the scientific community is taking, but asking different people. At the first level, when you get to publish on a scientific journal, you ask a peer, another scientist, judge your own research. Then when you ask, is this relevant to clinical practice? Is this relevant? Is this new? You don't ask scientists anymore. That's not their business. Their business is judge the robustness of science. If you want to know if something is useful on the field, you have to ask people on the field. That's why with PAIN Plus, we ask practitioner active in the field. That's the only requirement we ask them. We ask them if they are still practicing pain medicine. Now, if you want to know what's worth being written in a lay format, you have to ask lay people. Educated lay people that have been trained to do this job, but essentially is lay people. So we offer a chance of registering also for lay people as a public jury member. And essentially, you volunteer to receive selected articles out of PAIN Plus. There is an editor who make an initial judgment, and it can be a surgical technique that is describing how to do anesthesia one way toward another. Very likely is not relevant to patient, or maybe instead a piece of evidence that may answer one of the questions that I showed you before. So if the feeling is this might be of interest for patient, that's sent out to the jury members. So lay people register here, and what it happens if they register is they receive an email, and this email say, we added one new evidence summary candidate to the PAIN Plus CPN system. We'd like to have your judgment on it. And you click on this big orange button, and you move to see what the candidate is. And so you recognize PAIN Plus. This is a candidate improving adherence to long-term opioid therapy guidelines to reduce opioid misuse in primary care. A randomized trial. So this is a trial, a single trial where they checked if the measure to increase the application of guidelines for proper reduction of opioid, for reduction of use of opioid when not appropriate, do work. Problem is there are guidelines that suggest to use opioid as needed in a few conditions, and identify a few ways where opioids may actually do more harm than good, and give suggestion about avoiding using this medication in those situations. This study is about how can we ensure that those guidelines are better understood and better implemented. So this is sent. What you can do here is click on PubMed and read the abstract, or read the entire text if you want. Usually is not needed to read the entire article, but we make it available for everyone wherever they are. You don't need to be an academician. You don't need to be affiliated with an hospital. You are reading to help selecting a piece for writing an evidence summary. You have right to access, so you can read it, but sometimes it's enough to read the abstract. This is not an easy reading. This is scientific reading. So sometimes it requires some training, but there's no other way at this stage. Someone has to understand what happened and tell, okay, this would be useful communication for patient. And of course, we need to understand what the question that this piece of evidence would be answering, what the question of interest to the lay public that this piece of evidence would help answering. So essentially what we, and you know, you can tell from here if this was successful or not. This study may end in saying there's no point in doing webinars, they don't work. Or do webinars, it has been shown that wherever you do webinars, then the application of the guidelines is better. Only those who will have side effect are denied opioids, and actually you end in giving opioids to more patients instead of less if you apply the guidelines properly. It's very difficult. You can't tell from the title. You have to read it. Once you have read it, what we ask is, do you think that this would be good for patient with pain, doctor treating pain, or policymakers? We don't assume that only patient may benefit from a lay version of evidence. Maybe policymaker would. Rarely they read directly science, and so having a piece that is written with the optic of, well, this treatment should be made available in BC, and this evidence would support providing this treatment, may be a goal. So you may say, you know, I don't need to know as a patient, I know already, but this would be important to broadcast to policymaker, or I know my doctor would need to know, and vice versa. So we ask, and the answer is, again, 1 to 7. We like a lot 1 to 7, but we don't ask a number. We say, is this relevant to patient? Highly relevant, down to definitely not. And same is for policymaker and for healthcare professional. And also, we ask, and this is optional, what would be your bottom line from reading what you have read? what you think we should stress out as the bottom line. You recall that line that I showed you in the beginning, that very simple summary below the title. What would be your proposed bottom line? And finally, we say, if we select this piece, would you like to read it? Would you like to read the draft and help us going to the right conclusion? Now, again, if you go in and you log in, you will see the one you have to rate. This rater let 4 pile up there. He has 4 to judge, and below the one you have rated. For the one you have rated, after you give your judgment, you give your vote, and you write your comment, if you click here, you will see what the others said. Usually more than one person received the same. And after you vote, you'll see the other. So in this case, he went to 3. And for patient relevance, 2 said probably, 1 said highly relevant. For healthcare professional, 2 said probably, and 1 said highly. And instead, for policymaker, a probably, a definitely, and a highly relevant. So this one seems to be on spot. One of them left a comment. Now, I use this one in hopefully readable size for you to read. But again, this is another one. See how many decided to give their score and decided to leave long comments. And this one we ended in use for an evidence summary. It's failed back surgery syndrome. So by reading the comment, by reading the scores, we select the one for which we write the summary. Now, going back to the summary, circling back, and I'm almost done, circling back to what an evidence summary is, you can also print it out, and can be printed by a lay person and brought to their doctor, can also be printed and handed over at the doctor office. We have some that are good educational material, and some of our PAIN Plus user, they print them out and give them to patients for whom they might be relevant. Now, the printout is very unprofessional. We work in economy, is readable, but is not fancy. As is not fancy the layout on screen. And here is where I wanted to show you OClock Class, and here is where my mistake came from, because I was at this point using material from OClock Class. OClock Class is a similar service in the space of deep venous thrombosis. And you see that the layout is different. We will move on PAIN Plus to this new layout before the summer. We have started on this one because we got a little grant to do this restyling, but now that the technology is acquired, it will be rolled over to PAIN Plus as well. And the other thing we have introduced is that if you scroll down, if you click here on what the issue, it will expand. And now you see that there are these words that are black and underlined. So for example, pulmonary embolism is still a bit of jargon. So all those words expand into a lay person description. You know, if you read some of these, after a while, you will know what is a pulmonary embolism, but if you don't know, it will pop up. So neuropathic pain, once we move to this technology, we'll have a bubble up coming that will say neuropathic pain is this specific pain caused by nerve damage, irritation, and so on. Also we started writing also summaries for general practitioner, and when we have the same for both, they are linked together. The printout also, the one that you can get somewhere you can print, this is a low quality image, but that is a bit more catchy, can be printed in color, there are icons, is the same content, just formatted in a slightly more professional way. Just to give you a dimension, how many users are on PAIN Plus currently? a little more than 1,000. 800 of them receive alerts. How many alerts we send out? In the month of May, we sent out 700, which is little less than 1 per person. So the number is there, 700 emails sent, but the user receive only the one pieces that they need. So it's not contributing to the infodemics like COVID. You open the email and you have 10 on COVID on the first page. Not saying that that's not important, saying that we are trying to only funnel what is really needed. How many of those alerts are open? About 450. We are very happy. It's quite a good opening rate for a service like this. And by the way, in the email, you read the title, and the title is per se enough to let you decide if it's important or not. We don't presume that every single piece we send out will be of interest of everyone. And so we are happy with this opening rate over a month. How many articles we have selected over 5 years? Because PAIN Plus has been active now for 5 years, 6 years actually, including the prototype that we use for the CHR application, about 5,000, which is still a large number. But if you spam it over 5 years, is a reasonable number, is a couple of articles per day, and they are organized in disciplines, topics, and so everyone needs really to read only a subset. To give you a sense of how popular these are or are not, the most I mean, this is a sum of reading on the website or downloading of the article, and is the one on cannabis and cannabinoids for non-cancer pain was 1,300. Chronic pain, craniosacral therapy, 1,200, and so on. I posted here the first 10, I think, by frequency, and you see that all the 10 got around 1,000 access since they were published. So of course, if they were published earlier on in the process in 2017 or 2018, they had more time accruing hits. It's not really comparing one with the other. It's just giving you a sense that we feel this is not the solution to the problem, but it's not something that no one uses. There are a decent number of clicks, even if this is small compared to how many patients with pain are out there and how many doctors involved in treating pain are out there, but makes us feel that it is worth carrying on with doing this job. Now, my last slide, I think, is to open up opportunities. We don't think that this is the end of the story. Yeah, it's the top of the pyramid, but it's not the end of the story. This is something that, yes, can benefit someone reading it. They get exposed to good science, and they now know what the content out of a scientific paper is in a hopefully understandable and simple format. But this may be the beginning of getting into much more effective communication channel. It would be nice if any of those being sound pieces of evidence, so we have no doubt that they are true. There is no advertising, no pharma involvement. This is all just pure appraisal. And now they were deemed to be patient relevant and new. And now they were also reduced in a lay format. Can you imagine any better place to start for a blog discussion or for making some advertising? Very often we get on the news articles that 3 days later are retracted. I mean, again, COVID is a typical example. Study result where we invested millions of dollars, not in Canada, luckily, were retracted 3 days after and said, oh, I'm sorry, that's not true. These pieces of evidence are true, are already partly translated, why not using them for dissemination? I forgot to show you on the website, you can tweet, you can post on Facebook, you can forward to your acquainted connection and so on, or can be used to prepare patient-oriented material. A single piece of evidence is never all what a patient needs. You may need to combine different pieces and create something on this kind of pain. That's beyond our reach. We are not staffed and we are not able, we don't have enough expertise to do that job. We think that the pieces we produce with the help from the crowd of raters and all the patient and patient advocate that are involved as jury member is a good starting point. And here I would like to stop and open it up for questions.
Hi, sorry, just had to get back. Thank you for that presentation. That was really interesting. And yeah, I've been a subscriber to the service for a while, so I was like, it was really just interesting to hear your methods of getting those articles to us. So I actually do have a question. So again, if anyone listening has questions, put it in the Q&A or the chat, whatever you prefer. The question that's come in, and it's just around, well, I guess there's a couple questions in here. So you talked about jury members, and those, just to clarify, those are members of the public who are patients.
Yes.
And you talked about raters, and the
yes.
raters are healthcare professionals.
Yes, correct. So the raters, the one that do the rating for PAIN Plus, are healthcare professional and should be in practice. So you can't be rating, you can't be judging, is this relevant for doctors treating pain, physiotherapists involved in, you know, physical treatment of pain or rehabilitation and so on. You need to be a professional to provide that judgment. In terms of jury members, we prefer patient and lay public. Can be a patient, or can be, you know, a patient as a family member who's a journalist, or can be someone that is involved in pain as an advocate, can even be a professional, but he has to do the job with the mindset of a lay person. We don't require at that point a professional opinion. We require help in understanding what would be good to translate in lay language. So ideally a patient or a lay citizen, yeah.
And so, and like you, within your slides, you gave a couple of ways to participate. One is just to, as I understand it, like to go to the site and then see the articles and rate them. Yeah. But is there also, do you need to sign up for anything to become that jury member? And if so, how do you do that?
Is on the website. I don't know if I can pull up the website, but on the home page of the website, there is a button that says become a jury member. You just need to provide an email. And then you will start receiving articles that are already in PAIN Plus. And the question are those 3 questions I showed. Do you think this would be good to write for patient? Would be good to write for? If you have anyone that can't manage to do it on the website, feel free to send over a note, either to myself or on the website. There is an help. There is an help desk. You can write to the help desk saying, I'd like to collaborate. What can I do? And we will take care of setting you up. I got in the email already 2 emails of people that wants to, and we will certainly set them up. So it's feasible on your own, but if you prefer, just contact us, tell us what you think you can do, or, you know, if you are open to different solution, we know what we need. So just contact us. We will contact you back and set you up.
That's great. And then if you are a healthcare provider, as many people on this talk are, and you're interested in rating articles, is the process similar?
The process is similar. In that case, is by invite. So it says, contact us, or do you want to become a rater? It's not a self-registration. You declare it, and then we send you an email to invite you. And it would be nice to have a few more with interest in PAIN. In a way, is a sort of a volunteer kind of job, but it exposes you to a literature that is very likely to be good. And you may say, I want one per week, I want one per month. And we usually suggest not less than one per month, just to keep the expertise there. But if you want one per month and you want only knee pain, you will receive, when we have one, an article on knee pain is in your own field. You read something that is very likely useful. You help your colleague by making so that if it's really important, you received it to score it. The other will receive it as, he scored it, he think it's good, just read it. So it's a sort of community help.
I see. Okay. And then someone is asking, so is there training provided? And I'm not sure if they were referring to for the jury or the rater job, but I suspect I'm curious about.
Yes, for the rater job, there is one pager, and the main message is, don't worry about quality. We are happy when you signal that there might be bias here, there was a problem in this study conduct. We like everything. But in general, methodologically, the studies you received are already good. We assess that they are good. What we need from you is this relevant? We don't know what is really needed or not on the field to treat this very specific form of migraine. So what we need is, you assume this is good. You may tell us, yeah, it's good, but it's a small study, and there are 3 others that are contrasting. I don't think it's that new. That's what we need. We need some judgment about how this is received in your own field, in your own community of practice. We ask our raters to answer on behalf or thinking of their colleagues, those doing their job in that space.
Yeah, okay, that's great. So they just need to read the one pager. And then for the patient jury, is there any training for them?
Yes, for them we take a little longer. And we have felt that it's better when we have new patient that wants to help, to just invite them on a Zoom call and then we guide them and we let them ask questions. We do a few ratings together. There are some of the patient already member of the jury that do this in a beautiful way, some from VC. And so if they have time, we say, well, this colleague of you would help you. If not, our staff does. But yeah, we have never thought of recording a webinar. We like the interaction and we like the chance of asking questions. The jury member are about 20 currently. So even if we add 2, 3 more, it's still manageable. It's not thousands of people, of course.
Right. Okay, that's helpful. And then it sounds like, because the other question is about how much work is involved to be either a rater or a jury member. It sounds like you can kind of say what your commitment is, and you'll only get as much as you want.
So for the professional, we suggest if you sign up to sign up for the minimum or more. Is one per month. Now, how long it takes? It depends how catchy the article is for yourself. It may take as little as 10 minutes, or it may take as long as half an hour. Every one of us has a different way of reading articles and judging. Sometimes you receive an article you have read already, so it's very quick. So the time for a professional is between 10 minutes and maybe half an hour per article. If you sign one per week, will be 1 hour. We provide a certificate that can be used with the college for credits. We don't provide credits ourselves, but end of the year, we'll tell you, you have read 10, 12, you have read 24 articles. This is equivalent to 3-hour college training. You can submit it as self-certified training, and the Royal College accept it.
Great.
For patient, it depends very much on your level of how familiar you are with. It may take longer in the beginning. Patients tell us that usually it takes between 1 hour and 40 minutes to read an article, understand, and come up with a judgment. How many you receive depends on you. We send to everyone in the jury, and we need 4 or 5 judgments. So you may decide, I don't read this one, it's too complex. You just ditch it, and you read the one you feel you have a contribute to give on. So it's flexible. Everyone can contribute as they like.
Yeah. Okay, that's really helpful. And then finally, this was a 5-part question. Finally, what's the time commitment? So when you sign up to be either a rater or a jury member, are you committing for the rest of your life? Are you committing for a year? What is it?
You commit to as long as you want. It's volunteer work.
Right.
And by the way, I see a question in the chat, in the Zoom chat. You can just be a user. All of this is for free. We live in a world where, you know, every help is welcome. If you want to help, we enable you to do. But if you say, listen, I'm busy, but I have paid, I'd like to receive these summaries and read them, that's fine. You just sign up or go there and read. It's all free. There is no registration fee for seeing. This was paid by CIHR and still is. So no need to register. You can register if you like. If we have to send you an email, you have to give us the email. But if you want to go there and read, but even for sending you the email, there is no cost. You just put the email there and we'll send you what you want.
No, it's amazing service. It's just excellent. So thank you for all your work on it.
My pleasure. Thank you for all those collaborating with us, the raters and the jury members. We would not have this service without their contribution. So I welcome your thanks, but I want to extend the thank you to all of them.
Wonderful. Well, I'm not seeing any more questions, but I really appreciate the clarification around the jobs of the jury members and the raters, and just overall lots of, oh, hang on, sorry, I always say that, and then one more question comes in. Oh, no, just one. One thank you for an excellent presentation. So yeah, that's very, very nice. So thanks to everyone for coming today and spending your lunch hour with us. And thank you to you, Dr. Iorio. We just so appreciate hearing about this service, and it's just fantastic. So look forward to reviewing some of those evidence summaries myself.
Thank you very much, and have a good afternoon.
Yes, you too. Bye-bye, everyone.
Bye-bye.